Hi, this is Dr. Mays. I wanted to talk to you a little bit today about what types of exams we order for hip fractures and people that fall down, and explain the importance of doing hip films versus pelvic films, and hopefully answer a couple questions that people have. So the first thing in general is just whether or not to order a hip or a pelvis. And I can tell you from experience that radiologists greatly appreciate it when you get a pelvis with a hip. And that's just because we have a comparison for the other side. A lot of times the fractures in hips, especially in the elderly patients, are really rather subtle. And so having that other hip, even though it's an AP view of the pelvis, being able to see both views is very helpful for us. There are other considerations to take into account when we're talking about CPT codes and exactly what was ordered. But in general, we really want to do a two-view exam of the hip that we're questioning, and then also pelvis. One common thing that comes up is the technologist will say, oh, well, the patient was in a lot of pain, so we just did one view of the hip, and that's all we got. And that's all fine, but I can tell you, as soon as that patient gets to the emergency room at the hospital, they're going to repeat the exam. So they're going to do an AP view of the pelvis, and they're going to do two views of the hip. So you're really not helping your patient at all by not doing the complete exam. I know that the patient's in pain, and I know that it's a little bit difficult to do, and none of us want to cause our patient pain, but in the long run, you're doing the better thing for them because you're getting them the right diagnosis. Because there's nothing worse than we get our patient to the emergency room, we did a single view, and it turns out it wasn't fractured. So we transfer that patient there, they do the right exam at the hospital, and they find out it's not broken, and we've transferred them for nothing. Likewise, we have a patient, we did one view on the patient because they were in a lot of pain. We called it negative, and 2 or 3 days later they're still having pain. We finally do the correct exam where we do an AP view of the pelvis and two views of the hip, and now we see the fracture. So it's really, we want to maximize our chance of seeing these fractures from the beginning and do what we can to not miss those. Having said that, as I reviewed in the fractures in general, a impacted fracture is nearly invisible on an x-ray. So we really have to see some sort of displacement. If there's not displacement, it's really hard to see some of these fractures. And so if you have a patient that fell down, you have a high index of suspicion, and it's not displaced, so in other words, we don't see it on that initial x-ray, what we will usually say is non-weight bearing and follow-up exam in 3 days. So in that 3 days, what that's going to do is it's going to give the osteoclast a chance to come in and start eating away some of that dead bone, so we have a better chance of seeing that fracture. And oftentimes it may at that point displace by just a millimeter or two, and it allows us to see the fracture. Now, these aren't patients that have a displaced fracture. If they have a displaced fracture, obviously they need to go to the hospital and get treated. But if they have a non-displaced fracture, waiting 2 days and repeating the x-ray to prevent an unnecessary trip to the hospital, it's not going to really do them any harm in the long run. They're going to be in pain, and we have to manage their pain. But those patients that fall down and have a negative film and have no fracture are still likely going to be in pain. So we still are not in any different situation because we're still just managing pain. And so it's important to, when we look at the radiologist report, if that radiologist says, I don't see a fracture, but I see something that looks just a little bit weird here, not enough to call a fracture, let's keep that patient non-weight bearing, follow it up in 2 to 3 days. And then if it's a fracture, we have a pretty good chance of seeing it. We still may not be able to see it. Again, an impacted fracture that's not displaced is pretty much invisible on an x-ray. We're just not going to see it. There's some secondary signs, but for the most part, even the best radiologist is going to miss some of those non-displaced fractures. So in that case, when you follow up in 3 days, if they're still having pain, that's when you send them to the hospital. So that's when you send them out. Likely they're going to get there, they're going to end up having to get a CT or maybe even an MRI to see that fracture. But so what we don't need to do is send everybody out that has a negative x-ray. It's reasonable to wait a day or two. And like I said, 2 to 3 days is not really going to do them any harm in terms of treatment. The other thing, make sure we do all the appropriate views. So by just doing one view, our patient may be happy with us in the short term, but they're not going to be happy with us in the long term because they're going to have to go to the hospital and they're going to repeat the entire exam. So whatever we did, they're going to do it over. In terms of just kind of briefly discussing CPT codes, I just wanted to mention a little bit. When we order a pelvis and a hip, The radiologist is going to prefer a single view pelvis, so an AP view of the pelvis, and then two views of the hip. So say we're doing the right hip, we'll do an AP view of the pelvis, we'll do an AP of the right hip, and we'll do a frog leg view of the right hip. That's going to allow us to have the best chance of seeing that fracture. I would say the view that gets cut out the most, obviously, is the frog leg view. And really, that's a pretty helpful image that we have to aid us with finding the fracture. If you're keeping track for CPT codes, that one in particular would be a 73502 for the CPT code. If you did happen to do a pelvis and you only did one view of the hip, so if you did an AP view of the pelvis and then you used that pelvis view kind of as your AP view of the hip, and then you added an additional frog leg view of that right hip, then you would use a different CPT code. That one is going to be the 73501. And so those are the two most common CPT codes. And again, I'm not trying to give billing advice here. I'm just talking in a general sense. I'm certainly not a master biller, but that's how the billing goes in terms of the pelvis and the hip. And again, it's really advisable that we have a pelvis and a hip when we're worried about an injury. In general, high-impact traumas, car accidents, things like that, they tend to break their pelvis. But elderly patients in the nursing home that just slip and fall, they tend to break their hips. So if we just do a pelvis and we don't do a hip at all, we're probably not going to see the fracture, or we may not see it adequately. In terms of the pelvis fractures that old people do get, they tend to be the ischial tuberosities. So I'll show you an x-ray here in a second and show you exactly where they tend to break them. But they don't break generally in the same places like a trauma from an MVA. That's a whole different story. And finally, the last choice is if we're not sure which hip is the problem, a lot of times we have to do bilateral hips and the pelvis. So we do the AP view of the pelvis, and then we have a choice. We can either do a 2 view of the right and then a 2 view of the left, so a total of 5 views of the pelvis, which would be CPT code 73523, or we can do the AP view of the pelvis and then a frog leg of each hip, of the right and of the left, and we use the AP view of the hip on the pelvis exam as our AP view, so a total of 3 images, and in that case it would be a 73521. All right? So now I want to show you a couple of views of the hip. So this would be an AP view of the hip. This one would be a frog leg view of the hip. So this one is where we're kind of externally rotating the hip a little bit. It allows us to see the femoral neck a little bit better. It's overlapping the trochanter. So just from an anatomy standpoint, this is would be the pelvis up in here. We're coming across here. This is the superior pubic ramus. This is the inferior pubic ramus. This is the ischial tuberosity. So when old people fall, in terms of pelvic fractures, they don't tend to break their acetabulum as much or their iliac wings. They break their superior pubic ramus, their inferior pubic ramus, or sometimes their ischium. In terms of hip fractures, however, we're looking at, this is where the money's really at for our elderly patients when we're talking about hip fractures. So we see the femoral head is here. This is the acetabulum. This is the greater trochanter, this is the lesser trochanter, this is the femoral neck. Now, one important thing to remember when we're describing these fractures in our reports, we're going to describe whether or not the fracture is located. When we're talking about, whether or not the hip is located. So when we talk about a fracture, I may say there's a subcapital, which means a fracture just right here at the base of the femoral head, at the junction between the head and the neck. That's a subcapital fracture, but I also need to tell you if the hip is located. And so I'll say the femoral head is located, so that means the head is located in the acetabulum. So that part is good, but there's a fracture, so a subcapital hip fracture with the femoral head being located. And so I think a lot of people have a little bit of trouble understanding what we're talking about when we say the head is located. I know Bill tonight called us and was really thrown off by the fact that we said the head of the hip was located, but there's still a fracture, and he didn't understand that. And it's because we're talking about two different things. We're talking about dislocation of the hip versus a fracture of the hip. You don't typically fracture your hip and dislocate it at the same time, although you can if you're in a trauma. But for the elderly patients, they typically don't tend to break it and dislocate it at the same time. Most likely, they'll dislocate it, and surprisingly, it doesn't break. Femoral neck fractures are going to occur in this area here. Again, this is a greater trochanter and lesser trochanter, so you'll see an intertrochanteric hip fracture here, and then right here is below the trochanter, so you will see a subtrochanteric hip fracture. So we have subcapital hip fracture at the femoral head-neck junction. We have a femoral neck fracture. We have a intertrochanteric fracture, and we have a subtrochanteric hip fracture. So those are the different words you're going to see in our reports describing those fractures. And again, this is the AP view of the pelvis that goes with that 2 view of the hip. Sorry about the zipper on the patient here, but so we can see the femoral heads, we can see the acetabulum here, we see the ischial tuberosity here and here, inferior pubic ramus, superior pubic ramus, symphysis pubis. And the other thing that's nice about the pelvis view is we do see the sacroiliac joints here and here. We see the sacrum right here, so we see the ala of the sacrum. Sometimes they get a fracture in this area. We do see the acetabular roof here and here, and we see the iliac wings out here and out here, and we see the greater trochanter and the lesser trochanter. So lesser trochanter and greater trochanter. So the pelvis view, the AP view of the pelvis that goes with the 2 views of the hip, is very beneficial to us. And finally, I wanted to end with the fracture here. This is the one that we actually had tonight that Bill called about, and this is a hip fracture here, so it's kind of at the femoral neck. It's not quite a subcapital fracture, but it's a femoral neck fracture. But you can see the head of the femur is located in the acetabulum. So we have not dislocated our hip. So even though we broke our hip, so we broke the hip through the femoral neck, the femoral head is still located and we haven't dislocated our hip. And one thing I want you guys to all notice is even though this patient was in pain, they had no problem doing the frog leg view and the AP view of the hip, which again is going to be very important when we're trying to make our diagnosis. And this way, when they get to the ER, when they get to the hospital, they have the images, they have the report, and at this point, the orthopedic surgeon can start deciding what they want to do with the patient in terms of treatment. If we send them with one view of the right hip, they show up there, again, the orthopedic surgeon is going to have to repeat all the exams of that hip, so they're going to have to start over. So it's important that we get both of these views along with our AP view of the pelvis. Points I want to make before we finish up here. Again, if we have something that looks funny but we're not sure if it's a fracture, let's put them non-weight bearing and follow it up in 3 days. So don't let them walk on it. Let's follow it up in 3 days, give those osteoclasts a chance to get rid of the debris in the fracture. Hopefully we'll see it. When we're worried about a fracture on a hip, let's get an AP view of the pelvis and 2 views of the right hip whenever possible. I understand sometimes it's completely out of our control. We can't do anything with it, but that's what we have in an ideal situation. And then if we're not sure which hip it is, we may have to do an AP view of the pelvis and then look at 2 views of bilateral hips. So you end up with 5 images, but that's sometimes what we have to do if we're not sure. And then the last thing is just the terminology of located versus non-located. When we mention the hip is located or the femoral head is located, we mean that the hip did not dislocate when that fracture occurred. So there's still a fracture, still very abnormal, but the good thing is the femoral head is not dislocated. The reason the head being dislocated is important is you have about 4 to 6 hours to get that femoral head relocated in the acetabulum. If you don't, the blood supply gets cut off and you end up having to do a total hip arthroplasty on some of these patients that may be able to be treated with a simpler treatment in the long run. So that's the terminology you'll see. Thank you for your time. This is Dr. Mays with Emergency Teleradiology.